اوكي
think
تيك ذا
I
ليد
leave.
دكتورة فاطمة يلا.
Okay, I don't know if you can see my slide.
Yeah, we can see your slide now.
No. So the first question was about dual AV node physiological. Dual AV node physiological, it means that the flu go from time to time by the fast pathway and the other time by the slow pathway. So in the ECG, like you see here, we have for the second QRS, we have a normal PR interval. It means that it's going down by the fast pathway of the AV node. Okay. For the second, for this, the third QRS here, we have a longer PR interval. It means that switch to slow pathway and go down by the slow pathway. So sometimes this criteria it's very important to make like differentiation in patient who had narrow QRS. So it's cool. It lets us to say that this person is probably have AVNRT. Dual AV node, dual AV node physiology, we can have it, but without symptoms. It doesn't mean that obligatory this person will would have narrow tachycardia. So that is the definition. So that is the answer for about the first question. So the second question was about. You see my slide? It's okay. Can we go
Yeah.
to
Just to clarify, Dr. Fatma is answering the questions which are in the chat, which were mentioned in the chat.
what? What is the question?
No, I'm clarifying to about that you are answering the questions that were in the chat.
Okay.
Okay, go on, please.
Okay. I have, yes. For the second question, the second question was how can we differentiate between the AVNRT and AVRT? So the most important things, differentiation, when we are trying to make difference between these two kind of narrow QRS, we have a lot of kind of criteria in the ECG during tachycardia that we have to list. The first one that we see that is the RP interval. So here, as you see here in this slide, on our left we have the AVNRT. So the mechanism of the AVNRT, that's the tachycardia, go down to the ventricle by the slow pathway and up to the atrial by the fast pathway. So the distance between the V, it means the ventricle and the atrium, is the RP interval. It's very narrow. So the distance is very narrow. So in the ECG, we will have PR interval less than 95 milliseconds and a lot of books. It's the number that we fixed in the ECG. So during electrophysiology, it's less than 60 milliseconds. So the difference with the accessory pathway is distant from the AV node. So automatically, time consumed is more than an AVNRT. So the RP interval will. Okay, so just difference if we are talking about typical AVNRT and AVRT. And after that, we will see another criteria. So that was the first question. And the second question in the same topic, what is the difference between slow AVNRT and slow fast AVNRT? So the difference is just the pathway that we will take during tachycardia. In atypical tachycardia, we have, if you want, two most frequent atypical tachycardia is fast slow and slow slow. The common part between atypical AVNRT that the flow go up to the atrium using the slow pathway. So here we will have RP interval longer than comparing with typical AVNRT. So that can make confusion with other kind of narrow tachycardia like AVNRT. So that is the difference. So in the same topic, the question was if that affect the ablation technique. No. The ablation technique is the same things. We apply it the slow pathway, not the fast pathway, because we have risk of AV block if we touch the fast pathway. The fast pathway is near to the AV node, to the compact constriction of the AV node. So the risk of AV block it's higher. So we go down to the slow pathway and we ablate it and all kind of AV NRT, and the success rate is the same in typical, atypical, with some consideration if sometimes we have more than one slow pathway, and during tachycardia it can be conducted by two with like alternates, or we see like modification in the rhythm of tachycardia. So that's it was the answer about the second question. The last question was about fascicular VT. So fascicular VT is like a kind of VT that is very typical, and it's very characteristic. The first difference with other VT that the QRS are narrow, is less than 120 millisecond, and this affects a lot of time young adults with normal heart structure. It means no heart disease. And typically in the ECG, as Dr. Rosasi shows, is right bundle with left axis. And here we have schema that illustrates the mechanism of fascicular VT. We are using the fascicular structure. That's why the beginning of the QRS are very fast, and that's explain why the QRS are narrow in this VT, and it's a reentrant circuit involving the left ventricle fascicular. And this VT are very sensitive to verapamil. The last question was, how can we differentiate between sustained and non-sustained? Sustained SVT or VT and non-sustained SVT or VT, it's by duration, is less or more than 30 seconds. I think that was all the question that I see in the class.
أنا سامع الرحمن وظهري.
Okay, thank you very much, Dr. Fatima.
You're welcome. Thank you.
Is Dr. Margaret here?